All right. Well, it is a true pleasure to have on once again Dr. Felice Gersh. Welcome.
Well, thank you. It's a pleasure to join you again.
Wow, we had two great episodes together. The first one was the number one most listened to on my podcast for a long time, and it was called Hormone Therapy for Menopause, Good or Bad? And we know the answer to that one already. But we then covered mammograms in our last episode together, and I
Yeah.
got such great feedback, especially the YouTube people. They really, really like that. And this time I want to take a little deeper dive into some of the things that we need to know about hormone therapy that are a little bit more controversial. So I'll have links to those past episodes in the show notes for those of you who want to listen to those. But let's start with what you're known for actually in this sort of menopause world, which is the supraphysiological dosing. And let's share what that means and then why you're a fan of this kind of dosing for the women who are going through the menopause transition.
Well, in terms of the super, I would call it more instead of supra, I would say super, because what I'm trying to do is actually reasonably replace hormones at a level, a dosage that would create serum levels that are reasonably comparable to the levels that a woman would have at her healthiest stage of life, say when she's in the early 20s. Now, what became the norm and really the beaten into the ground kind of a policy really was low dose. So low dose became the norm. So anything above that was considered a supraphysiologic, but in reality, it was there was so much fear that was created after the Women's Health Initiative study came out over and was stopped over 20 years ago now, that the mantra of less is best and avoid if possible really became the mandate almost in terms of what all the medical societies recommended. And it really sort of became the foundation of how future studies were even designed, which is really sad because the studies even went lower sometimes in their dosage because they wanted to just use less, because the philosophy was it's so dangerous to use hormones that we want to use the least possible amount to only do one thing. And in terms of applying it in a clinical setting, and that was to suppress night sweats and hot flashes, which it turns out only a whiff of hormones can actually seem to help that. In fact, you don't even have to have levels that rise above menopausal levels, and you can still have some benefit in that one realm. But in terms of trying to then do things for healthy longevity, when they did other studies that came after the Women's Health Initiative, like the KEEP study or the ELITE study, they continued to use very low doses. And so that's a problem. And my look at it is like everything. If you want to exercise, don't do the bare minimum to stay alive. Do the optimum when it comes to eating vegetables. Eat optimal, sleep optimal. Everything is optimized amounts and levels, not minimize to the bare essentials just for survival. So that is actually a new way of thinking. It used to be more a normal way of thinking in medical care. You don't do minimal amounts to stay alive, you do optimal. But that really hasn't become the standard yet, not at all. And so I'm trying to get the word out that optimal is better than minimal. So that's the way I approach it. It's a really simple way of thinking, and it's how we apply pretty much everything else in healthcare.
It's such a great way to put it, actually. We wouldn't just eat the bare minimum of vegetables. So why do the bare minimum of hormone therapy, especially if you're looking at longevity post-menopause, if you're looking at bone health or breast health or brain health? And do we have studies that are showing that higher levels where, because as I understand, we need to have a certain amount of hormones to be able to protect our bones, our heart, our brain, etc. So Or are we not seeing it just enough for people to be convinced with? What are you finding in your research?
Well, there is some data. Sad to say, the amount of research is never enough. And most of the research that has been done has been in other animals, particularly rodents, which is a reasonable but not an identical replacement for human effects. And it's really very contrived how they actually create these models in rodents. So, but we do have some data in humans. And in humans, we know that unless you cross the line and have at least a 50 picogram per mil level in the blood, you're not going to do anything beneficial for vaginal health. And that's not even a high amount, but you really can't just give a whiff and systemically and then have vaginal improvement. The same thing with the bone. They've shown that the amount of estradiol that's delivered will have an effect on bone. So if you have a little tiny bit, it might help and could, and so it's not insignificant, help to prevent bone loss. But in terms of building bone, you have to have a higher amount. There was some data showing that if you're using the estradiol patch, you have to get up to the highest dose of the patch, the 0.1 milligram, in order to have the potential to grow any bone. So there is a dose effect. And there's a lot of research showing that it's like a bimodal effect of estradiol, kind of comparable to a menstrual cycle, which is a really good role model for estradiol levels and the effects. So the time of a woman's life when she's having reproductive function and she has menstrual cycles, when she's in the period time of the menstrual cycle, and day one of bleeding is called day one of a new cycle. During those few days, the estradiol level is the lowest, and everything is the most pro-inflammatory at that time. And the uterine cavity is inflamed. You're getting rid of dead and dying lining tissue, the endometrium. You're producing inside the uterine cavity pro-inflammatory prostaglandins, which create just like a mini labor effect. Like it's a similar, but on a bigger, grander scale when a woman goes into labor. You're creating these inflammatory products that create cramping. And in some women, when you have too much inflammation, you get too much cramping. And that's, of course, dysmenorrhea or menstrual cramps. So you're going to have a pro-inflammatory effect. We have effects on the immune cells, and when things are not right, that can trigger endometriosis, which is a massive inflammatory state in the pelvis. So we have a pro-inflammatory state that occurs during that menstrual period. Now, the least inflammatory, when we're the most anti-inflammatory, is when you have that really high spike of estradiol that's produced, that's preceding ovulation. In a menstrual cycle, first you have very low levels of estradiol, and then it rises, and you have this big spike. And then after that big spike, you have a big spike of luteinizing hormone, LH, and that triggers ovulation. When you have, after that big spike of estradiol, you have a dip, and then it comes back up and it goes highish, and then it plateaus, and then if you're not pregnant, it comes down. When you have that giant spike of estradiol, that is the most anti-inflammatory state. And all of this has a purpose. You want to have some inflammatory state when you're trying to have cramps, and that's inflammation. You're getting rid of the dead lining and getting rid of the lining. When you have that spike of estradiol, you want the least inflammatory state, because you don't want your immune system, which is the inflammatory response, you don't want your immune system to attack incoming sperm, or then set up the stage to attack and kill, your little embryo if you get pregnant. And progesterone in the luteal phase, the second half, is very anti-inflammatory as well. And the estradiol level is also on a relatively high level. That it gets complicated, because if you have a sort of an imbalance in the way the response is, then you can have sort of a dysregulation of your autonomic nervous system, and that can lead to PMS, premenstrual syndrome, that some people get. But by understanding the menstrual cycle, which is foundational to women's health, we can understand the effects of high and low estradiol. And there is no question that there is a bimodal, a different effect in the body on the immune system and on different structures. I mean, they've had some data looking at how the body responds differently to exercise and other different stressors during different phases of the menstrual cycle. So learning this, it is so important that what we don't want to do is, and this is what became the mantra after the Women's Health Initiative, to try to recreate the environment that would be in play during the menstrual phase of the menstrual cycle when you have the most pro-inflammatory state. So it's like they didn't get it at all. Not at all, because they were using the wrong products and they came to the wrong conclusions. They interpreted the data inappropriately and so on. So the bottom line is that's the last thing that we would want to do in menopause, is to give the lowest amount that recreates a more pro-inflammatory state. Now, I always have this little motto: any hormones are better than no hormones, because you're still going to have some beneficial effects, but you are certainly not going to have an optimal effect if you give this really low dose, which became the norm. So I'm just trying to have a reframing of how hormones work in the female body so that we can have a more nuanced and, we'll say, scientific approach to giving hormones. Once you cross that sort of unfortunate barrier that became embedded into so many minds, medical minds, the doctors and the patients, which was that tremendous fear, this fear of hormones, that they were going to turn on us and that maybe they were good once upon a time, but now they're bad for us. So we just made that leap, hopefully, but now we have to make the next leap, which is dosing and rhythms and how to actually utilize these hormones to optimal effect once we get to the decision, which I hope most people are coming to, that hormones are good and we want to get on them and we want to get them going in our bodies as early as possible in the perimenopausal time, before more, damage and effects of estrogen and progesterone insufficiency start affecting all the structures of our body. We want to be absolutely the most proactive. And this is also not the norm, to start hormones early in this process of ovarian aging and not think of that menopause, that arbitrary definition. When you have 12 consecutive months without a period, that's an arbitrary definition, because menopause is not a moment in time. The word is wrong. It's not doing justice. It's ovarian aging or senescence of the ovaries, and it's a process. And just like we now have an understanding of prediabetes, insulin resistance that even precedes prediabetes and then diabetes, or hypertension, we have pre-hypertension, hypertension, different stratums of different hypertension levels and so on. So too, we need to think not as a crossing the finish line, but as a process, just like with all these other medical processes. And we don't want to wait until late in the game. We want to start early in this process, because negative effects throughout the body are developing early in this aging ovarian process, not waiting till late in the game, which is what menopause would be, 12 consecutive months with no bleeding. So, we want to rethink everything about menopause and turn it into a positive light, not think of it as in a negative way, but in like everything in life, just accept what is, what is inevitable, and then come up with really useful, viable, scientific ways to approach it, which has not been the case.
What a great explanation for rebranding menopause. I always say menopause needs rebranding, because I agree with you. It's just like one day in time and defines everything. And what about all the women in perimenopause? And only now recently women are using the word perimenopause and starting to understand what it is. But I'm also thinking, well, we must have some other terminology post menopause, that date, because I don't think a woman's experience is the same in your 60s, 70s, and 80s. And we just haven't come up with the terminology yet. And so it's a spectrum, and not just sort of this finish line as well, because how many women do we know also in their 60s and 70s who are still dealing with hot flashes and night sweats and this all
Yeah.
the symptoms of menopause, and not to even mention the bone density loss and the osteoporosis and the heart disease. So it makes perfect sense to say, okay, well, we need to look at the ovaries as aging, and when do we start to bring in some interventions. And what you're really doing and pioneering in this field is getting the optimal levels of hormones, right? Like you just said, we're just barely getting there with, okay, hormones are now safe and good for you, but what about getting the optimal dose to protect our future selves? And that's, I always say to women these days, that's we're still in the wild, wild west here. Like
Yeah.
we don't have conclusive information that everybody can agree on, because you still have these, infighting in this world of what's good, what's bad, and it's an art to get your dosage right. And you've been doing this for decades now. And so I think there's part is the science, and we need more research showing, well, what exactly is a good general dosage to protect the bones or to protect the heart. And but the clinical experience counts too. And I'm sure over the decades, as you've been treating women, have you found any women who you've been treating, let's say 20 years now? And have you looked at their bone densities? Are they all just doing great because they've all got enough hormones? Or did you just go, oh, I was still in that not enough, and now they've got some osteopenia? Or what are you seeing in just your clinical practice with women who have now, gone 20 years on hormones?
Yeah, well, I'm in actually now the minority of doctors who were in practice when the Women's Health Initiative happened. And they've actually done some data collection, and something like 75% of all the practitioners, whether they're nurse practitioners or PAs or MDs or DOs, they were not practicing medicine 20-ish years ago when the Women's Health Initiative came out. And so they were taught, they went through their medical education at a time when menopausal education was pretty non-existent. There was like no approach. It was like hands off, it's life, lady, just chalk it up, and that's it, and I still hear patients get those kind of lines from going to doctors. It's like, you know what, this is part of aging, this is life, and goodbye, there's the door, because it's like we don't do anything, we don't treat it, it's natural. And so these doctors and other healthcare professionals were taught to avoid hormones. So it's really a challenge. And during the time when the Women's Health Initiative came out, I begged and pleaded with my patients to stay on hormones, that this made no sense. But, so about half of them, no matter what I did, about half of them went off. But of the ones who stayed on and stayed with me, oh my gosh, they have really defined what healthy aging is, and I hope that that's what I am. I'm trying to be a super ager and a role model, that staying on hormones and trying to keep the levels to a reasonably physiologic, semblance, so it's similar-ish. We wish we could make like a new set of ovaries, and there are people actually researching that, how we could have true ovarian function that goes on for another 20 years. And I would sign up for that, but we don't have that clinically available yet. So we make the best of it. But the patients who stayed with the hormones, and that I have been fortunate enough that they didn't move out of the area and so on, they're doing amazingly well. They did not develop osteoporosis. Their vascular system, and we measure vascular health in my office. I look at echocardiograms looking for the signs of energy deficiency, which occurs in an estrogen deficiency heart, which is called the initial stage is called mild diastolic dysfunction, which is a stiffer heart, an energy deficient heart. And I see that in women who went off hormones or were on minuscule insufficient doses, which is so sad. But the women who stayed with it, now, this is clinical observation. So it's not considered in our world today to be the highest level of scientific evidence. But if you think about how we learned as a scientific community predating big pharma and the origins of placebo-controlled double-blinded studies, we didn't learn by doing the big pharma type studies. We didn't do that. We learned by observation, clinical acumen. And so if I use that, the old-fashioned observational tools of learning and scientific evidence, which now, like I said, is not considered the highest level of evidence, then I would say my observation is that women who were on physiologic-ish levels of hormones, and not just physiologic levels, and this is another big deal, replicating somewhat the rhythms of a menstrual cycle, which is not what has become the norm as well. For no obvious reason, it's become the norm. Well, there is actually a reason, but it's not a medical reason. It's a social reason, which is not the same, right? Social reasons could be, I like to eat at midnight. That's not a medical reason for eating at midnight, right? So these are not, it's not a medically, justified position to use static dosing. But if you use rhythmic dosing, where you're cyclic dosing, those women did the best. But, this is like observation and not, a controlled study. I have no control group to compare to, but I can tell you that my observation is giving optimal doses, creating physiologic levels, and giving cyclic progesterone and maintaining a cycle with bleeding in women who have a uterus, which is, not the standard anymore. But like I said, it's a social reason, not a medical reason. Then those women did great, and they look younger too. They look younger because the skin and all the connective tissues that are in the skin, like collagen, and that make up the skin's and the hyaluronic acid, the ceramines, the fat, the good, healthy support fat, all of those structures are controlled and modulated by estradiol and progesterone levels. And when you have adequate physiologic levels, the skin doesn't age the way it does in women who are deficient in those hormones. And that is why when you see a couple and then you don't see them for several years and then you see them again, the female of the couple tends to age much more aggressively, rapidly than the male, because of this loss of these vital hormones for maintaining the integrity and health of skin. So my patients who've been on hormones in appropriate doses and regimens and so on, they look younger. I mean, and they're insides and outsides. So yes, I would, say 2 thumbs up for staying on hormones forever and using it in the right way, because that is, that's I'm so glad that we got to have this opportunity, because right now, and I'm seeing this and it's breaking my heart, but I try to keep saying any hormones are better than no hormones. There's been this gigantic proliferation of these mega companies that are doing online hormones across the country. And they're doing it in a way that is to try to keep it simple for the people who are prescribers, who I don't even know what background any of these people have, but they're using minuscule doses and static dosing, and they're really doing they're not doing an adequate job. But this is becoming a really growing industry of prescribing ridiculous regimens of hormones to women online. And I really have to speak against that, because it's really, once again, sort of poisoning the well in terms of understanding of what hormones are doing. But once again, it gets down to what is the purpose of the hormones. The FDA has only really approved, and the U.S. Health Task Force, which has a very influential voice, and they came out like a year ago with their new position statement, which was adamantly against the use of hormones for health, for healthy longevity. So the official position of the medical forces that be relating to our government, sad to say, are anti-hormone for health purposes, for healthy longevity. The only recommendation is still ongoing to use the smallest dose, shortest time for suppression of night sweats and hot flashes. And so if you look at it that is your only goal, then yes, small doses will often fit the bill for suppressing hot flashes and night sweats. So, it's a quandary here because we have opposing forces of like, what is the point? Like literally, what is the point of prescribing hormones? And so I keep writing and getting articles published like to try to get medical societies to change their position, because until you get like the American Heart Association or big or other organizations that create recommendations, like they create not mandates, but recommendations, which are often viewed by doctors as mandates, even though these are recommendations, but they think of them as standard of care, and that if you violate them, then like you're like doing terrible things. And it's still maintained by all these medical societies not to prescribe hormones for health, for longevity, for anything other than the night sweats, hot flashes. So it's not illegal, I have to emphasize, to use hormones for healthy longevity. It's an off-label use, and you're allowed to use drugs for off-label use. In fact, it's often more the norm than the exception that drugs are used off-label for all kinds of things. But I just wish that I keep trying to get medical societies to endorse hormones for optimal healthy aging, and it's just still not happening. So I'm like still screaming in the wind and hoping that I can make a difference here.
You are definitely making a difference and making an impact for sure. It's just not as fast as we like to be. And we still, like you said, the most of the research that has been done on minimal dosages and also more the synthetic rather than bioidentical. And they're not comparing the gels and the sprays and the creams versus the compounded versus there's still so much research that needs to be done, but it seems as though most of it is not looking at that. It's just kind of looking at the conjugated equine estrogen and just the
Well,
progestins, and we need
well,
more.
you're right. There's a lot of what are called studies that are called meta-analysis. So a meta-analysis, it keeps researchers and people who want to publish very busy. They're not actually creating new studies. They're simply combining the data of many studies and then trying to draw new conclusions or reanalysis. But the study that always dominates when they do these meta-analyses is always the Women's Health Initiative, because that's the study that had so many thousands of women. And so every meta-analysis is just the Women's Health Initiative come back, it's like it's here again. And because it is the dominant in terms of the numbers. And it's just so sad. And even the subsequent studies, they used, like I said, either still the wrong forms or the wrong doses. So, and it's really hard to get funding, and we're trying to get funding to actually do some research using physiologic replacement therapy with hormones. But it's really hard. There's so little interest when you have like the US Health Task Force and all the medical societies completely either coming down in a negative way or certainly not endorsing the use and not really interested either. Like they just like, no, here's our pharmaceuticals that we like, and there have been some really interesting new pharmaceuticals that have come up in the last decade. Some of these never get off the news, the news cycle, like, the GLP-1 agonists and the other variety that have like GIP in it too, and then the SGLT2 inhibitors as well, another different category of drugs that have been shown to help with kidney function and heart function and weight loss and insulin resistance. And it's so interesting because when you look at the scientific research, you have like the scientific, not clinical, because they're not in people, a lot of these, but they're in terms of looking at receptors and looking at how things work. Virtually all of these work better either with estrogen in the form of estradiol, they work better, or they don't even really work right at all if they don't have estradiol present, and or their enzyme systems or peptides that are produced in the presence of estradiol, so it's really an interesting thing, but there's research on all of that, but that's also not really talked about hardly, if at all, that a lot of these new drugs are really either would work better if you gave it to a woman who was in menopause and was on appropriate amounts of estradiol and progesterone, or if they were on appropriate amounts, they wouldn't need the drug,
Maybe. It's true. There's a lot, just, we need more research. That's very clear. Hopefully a decade from now, we'll have more answers for the next generation. But I want to I'm very curious to see the supraphysiological levels or the optimal levels and how this works with women, because I'm one of those cases where I started hormones 3 years ago when I was 50, and I just got diagnosed with osteopenia. And I'm like, how is that even possible? Well, it's because I've been on pretty baby doses. I've seen 3 doctors in three different three different years, and no one seems to have gotten right because I didn't have the symptoms. And so the problem is this is where exactly, and this is me who knows a lot about hormones already, and I'm just stuck in this thing. So this is why it's really important to get the optimal. That's what I'm working on now.
Right.
Let's get this up and get it to a decent level, because I don't want to keep going downhill. We can reverse osteopenia and reverse osteoporosis, and hormones is part of the puzzle. But I would like to learn to share a little bit more and learn more what you mean by cycling in progesterone. Are you also cycling in estrogen? Are you increasing it and decreasing it? How does a woman, one of your patients, for example, use cyclical hormones cyclically?
Well, I absolutely believe that the optimal way of giving hormones would be truly to replicate the rhythms of a healthy, normal menstrual cycle, which, as you said, the amounts of estrogen in the form of estradiol is variable throughout, if we say a 28-day cycle. Like I said earlier, you have this, it starts low, it rises, it spikes, it comes dips, and then it comes back up, and then you have the progesterone, and it starts low, and it sort of goes into a plateau, and then it would come down if you're not pregnant. That we do definitely need to get more research. I think that would be ideal. And that is not a common, that's like a real outlier to
Yeah.
do that. That's a super outlier. I really think that that will ultimately be the case. However, I also have to recognize that that is really complicated for a lot of women to do, because you're going to have a regimen where the amount of estradiol and progesterone is going to vary throughout a 28-day cycle. And that's really complex for a lot of people to manage. So what I mostly am doing is giving a static dose of estradiol. And I do sometimes do a little bit of variation to have a spike or start low and then end low, but most of the time, and that's, people get too confused, and it's complex, to give a static amount of estradiol, which would be sort of an average of what a woman would have through a menstrual cycle. Also, to tolerance, because different women will have different effects of estradiol. So I call giving hormones highly personalized, non-precision medicine. It's not precision at all. I call it ballpark medicine, because we want to be in a range that's physiologic. And when you look at the menstrual cycle, the variations in estradiol level are huge, from the lowest to the highest. So it's not precision medicine, it's personalized medicine, and it's ballpark medicine. And you really have to look at both the levels that you're getting in the blood plus the effect on the patient. In women who have a uterus, it's really a clinical gift if women will agree to this, and most will when you actually discuss it with them, if they're willing to have a pretend period. Now, it's pretend because you're not ovulating, but it's like a period because it's real blood. Okay. So it is real blood, but we don't want to make it like too heavy. You know, we want to make it last like maybe 4 days, and maybe like sort of like one day will be a little bit heavier, but then it just tapers off. And so it's not completely like life altering in a negative way, but it's such a great clinical sign when it happens that the hormone levels are in the physiologic range, because you're getting the uterine lining to respond in a physiologic way. And that's sort of a clinical tool. Now, but the uterus otherwise is not really our target organ for healthy aging. It's like, it's just there. So we use it as a tool. But in terms of giving the estradiol, I want to try to get a level that would be sort of a physiological level that would be in the range, that would be somewhat an average sort of what she would have in a normal menstrual cycle. Now, progesterone, that's another interesting one. Most of the time I give, say, a 200 milligram oral pill for 14 days. And if they're post-menopausal, in the sense that their ovaries are not making any progesterone or estrogen anymore, I usually just give it for the first 14 days of the month, because it's just easy. Remember, start day 1 and you take it for 14 days. And then the next month you start on day 1 again. And then you should have this little fake period anywhere from 3 days before to 3 days after. It should start from the last day of the progesterone pill. So it's okay if it starts a little before or a little bit after. That's okay, totally fine. If it starts like really, really early, then things are not happening the way we'd want them to. Now, what is the point of that? The point is that in order to get the effect of the estrogen, you have to give an adequate dose. Like, it's everything in life, it's dose related. You want to have an adequate response to exercise, you have to do more than 5 minutes a month. It's just what it is. Now, if you give an adequate amount of estradiol, among its amazing properties, many amazing properties, one is the stimulation of growth factors. Now, for example, in the brain, the estradiol triggered growth factors would be like brain-derived neurotrophic factor. Neurotrophic means neuron growth and effect on so you're growing neurons, you're rejuvenating them, you're repairing them, you're maintaining them. And there are other growth factors that create corollary, like ancillary blood vessels, vascular endothelial growth factor. So you have like more blood vessels supplying the myocardium, the muscle of your heart, so that you have better blood supply to all the different cells. And that's for healing. If you have injured tissue on your arm, if you have a wound or something, you got to grow new tissue. You have to have these growth factors. So it's about repairing, maintaining. And part of growth factors is the opposite. It's triggering programmed cell death, what we call apoptosis. So you want those old senescent, often called zombie cells, to kill themselves. That also goes along with estradiol. And autophagy, like internal cellular renewal, requires the estradiol, and you need it at adequate amounts and in the rhythms. So in order to get these growth factors to do all these amazing things, it's going to do what it does in the uterine lining, which is grow the uterine lining. The first part of the menstrual cycle, the first 2 weeks from the uterine perspective, is called the proliferative phase. Proliferative for proliferating or growing the uterine lining. It's just what estradiol does. So if you want to do everything to optimize bone growth, tissue repair, neuron growth, and everything else, all the reparative growth in the body, you have to grow the uterine lining, because it's a package deal. You can't target one organ and exclude another. It doesn't work that way. So you just have to accept that your uterine lining must grow if you're going to get optimal effect. Now, here's another little phrase I created. if you grow it, you must shed it. What is this? Like Jack and the Beanstalk? It's going to grow into the, next galaxy. You can't keep growing your uterine lining endlessly. That's not appropriate. And anything in life is supposed to be that yin yang, right? The fast, the eat, the sleep, the awake, the growing, the shedding. It's part of the cycles of life that maintain everything properly. So if you grow it, you must shed it. So by adding the progesterone in the reasonable physiologic levels, then you will convert the proliferative tissue in the uterine lining to what's called secretory. So it grows and grows, kind of like an adolescent boy. He like grows like a weed, and then he stops growing and he fills out. That's what it happens. The uterine lining, it grows, then it stops growing when the progesterone comes on board, and it like flowers. That's what they call it secretory, like it becomes all lush. So it doesn't grow anymore. But the progesterone puts the brakes on that growth. So you have to put the progesterone into the play, and it has to be in an adequate amount. And then for a particular time frame, which is like 2 weeks, that's what the body dictated, that's how we evolved. And then at the end, you continue the estrogen. We never have a time in our life when our estrogen just goes to zero. They're like, okay, take it away. That's actually bad. And there's actually data that if you stop estradiol abruptly, you can actually trigger vasoconstriction. You could end up potentially triggering a heart attack. So don't do that. People who say take 5 days off and just stop the estrogen. No, do not do that. More physiologic would be to maybe cut the dose in half. And I do that sometimes. It's just, once again, too complicated for most people. So we know this is not perfect, but it's good. It's better. Best is a new set of ovaries. I don't have that. So we call this better. But the progesterone comes and goes, the estradiol stays. And then when you withdraw the progesterone, the uterine lining becomes unsustained at that point, and it will shed out. And then you get that little fake period, but real blood. And we can make it, we have to modulate it for each woman so that it's tolerable. Now, like say someone's going on a vacation and she doesn't want to bleed and everything. Well, we could say, all right, just skip the progesterone that 1 month, because what's going to happen? Nothing, you're not going to give someone uterine cancer in a month. It doesn't work that way. So, you could just skip it. Or if you wanted to, you could use half the dose for that 1 month. Or, there's ways that we can create workarounds so that you don't bleed on your wedding, if you're getting married and you're, 55, things like that, which that happens a lot,
Yeah.
Or if you're going on a wonderful trip and you just don't want to bleed, we can create workarounds, so we can do it. But this is, so the way that it became, and by the way, the ELITE study, the KEEP study, they all used the rhythmic or cyclic progesterone. In the Women's Health Initiative, they used a formulation that was called PremPro. It was a combination of conjugated equine estrogens, the brand name Premarin, with medroxyprogesterone acetate, the brand name was Provera. So they put it together and called it PremPro. And the idea was that you wouldn't bleed. But here's the problem. It's like being in a car, the people who are on hormones where you have a static dosing of estradiol every day, the same, usually very tiny doses, along with progesterone every single day, usually a pill at night. Sometimes they combine it into, creams and such. But the bottom line is it's progesterone and estradiol and sometimes other estrogens, but that's another story. But we'll say estradiol, and it's the same dose every single day with the idea that you don't bleed. So that's like being in a car and no, there's no emergency brake on. You have to press on the gas and the brake pedals at the same time and not move at all. But you always have to keep pressing both at the same time. It's not physiologic. It's not what nature intended. So what the whole process of that, or the purpose of that, is to prevent bleeding, with the notion that no postmenopausal woman will accept having bleeding. That's like the best part of menopause, is that you don't have to have periods anymore. So that's a deal breaker. And for some women it is, especially ones who don't understand the sacrifice they're making by giving up having this period and having physiologic dosing. And all these clinics that are doing this online hormone stuff, They can't have patients bleeding because they're not even gynecologists. They don't know how to handle any of this. They can't deal with it. They're in a different state or whatever, so they're going to give these. And you, once again, if the goal is not healthy aging, the goal is just suppression of night sweats and hot flashes, which does have benefits. I would not, belittle the benefit of getting rid of night sweats and hot flashes, because there's harm in that. You don't get good sleep and you have stress. So that has a lot of negative ramifications. So I'm not against it. I'm just saying it depends on what you want. If you're ultimately looking for optimal healthy aging, then the lowest dose is not the optimal dose. But that if you're doing all this online stuff, or if the women are not told what the purpose of having a pretend period is, then why would they choose it? So here's the thing. In order to not have bleeding, you have to give a very, very small dose of estradiol, because estradiol does its thing. It creates growth factors. So in order to not create growth factors in the uterus, which it won't create them anywhere else either, then you have to give a very, very small dose. Then you have to give progesterone every day, because progesterone is like the brakes on the proliferation, just like I said in the menstrual cycle. So estradiol's receptors are down regulated by progesterone. There's this amazing interplay between hormones and the receptors, and different hormones and other hormones and their receptors. It's like really complex interconnectivity here. And progesterone downregulates the receptors for estradiol. So basically what you're doing is you're giving a teeny dose of estradiol to create marginal, if any, growth factor production and growth effects, no proliferation. And then you keep knocking down the estrogen's effect with growth, but it's going to change everything, because it's not just the growth factors. You're affecting many, many other functions of estradiol, involving the immune system, involving, other effects, involving vascular health, and it's going to affect every single organ system. You're trying to suppress the effects of estrogen with the daily progesterone, and you give a marginal amount, teeny amount of estradiol, and yet you can actually suppress night sweats and hot flashes even with that tiny kind of regimen. And so that part is good, but you're not necessarily accomplishing what you think you're accomplishing. I just want truth in advertising. I just want informed consent. So every woman can choose what she wants and understand what she's getting, So if she's looking for optimization, then you just got to do what you got to do. You've got to have enough to create what nature intended, growth and proliferation, which would include of the uterine lining. If suppression of night sweats and hot flashes is good enough for you, and you say, well, I'll do other things, that's good enough for me, I don't want to deal with bleeding, then that's okay. People should just choose. I just want to have people understand they're actually making a choice, and that there is a choice. That's like really important. So the bottom line is that if this whole thing of no bleeding became so prominent for a variety of reasons, and it really became like the most common, but not the best, but the most common way of prescribing, and some women are very happy on that. I'm not, and then they can use vaginal estrogen separately, because that's usually not anywhere going to be enough to maintain vaginal or bladder health. So then they use a separate product for intravaginal use, and they may be happy. And if they're doing everything else, like exercising, eating the right foods, going to bed, and they're doing all the lifestyle stuff, and they're lucky enough to have really good genes and so on, and they went into menopause in a healthy state. I call that your health savings account when you enter menopause. Women who are already metabolically unhealthy when they enter menopause have already 2 strikes against them. But if they're healthy as they enter menopause, those women may have become super agers. There's always that possibility, and we don't have long-term, data. Nobody really knows for sure what's going to happen to someone. But I work with medical probabilities. That's all I can work with. I'm trying to up the ante for medical probability of healthy longevity. But, every woman should have her own choice, but it really is a choice. And so it's really important to understand that the protocol of daily continuous estradiol and progesterone is concocted It's designed to prevent bleeding. That's all it's designed for, is to prevent bleeding, not optimization of anything else, just prevent bleeding. And sometimes it doesn't work and you get bleeding anyway, and then that has to be addressed. But that's really the whole purpose. And it's really important for women to know that there is never a time in any woman's life, any time in any reproductive years, any ever time in life when she has hormones like this in her body naturally. Never. This is concocted. This is not physiologic. No woman ever has this kind of a level and presentation and combination. It doesn't exist in nature. So I always say I'm a simple thinker. If I'm going to help people, I am not smart enough to micromanage every cellular function, every peptide and enzyme and signaling agent from fatty acids. I can't control on a micro level cellular functions and all the complexity that goes into it. I'm trying to do like the umbrella approach to health. Give the body all the micronutrients and the macronutrients. Give the body reasonably physiologic doses of hormones in the nature's setup, the rhythms that nature created for those hormones. Try to recreate what would be the time of life, like in the early 20s, when people generally are the healthiest. Try to create the environment that existed then for cellular function. Remember, every cell in your body, except for a very few, like in your brain or in your heart, all other cells of your body are different ages. They have a lifespan, they die, they get replaced from your stem cell pool. That's why stem cells are so important. By the way, estradiol helps maintain your stem cell pool, so you have stem cells to pull from. So, the cells that are born, they don't know the age of the body they're born into. They're just genetically programmed to do what they're genetically programmed to do. If you can keep what they get similar to what they would have had when you were in like your early 20s, those cells can still do the same things. Now, of course, that isn't really going to happen. We can't really make everything the same like you're 21, but we just want to do our best to come as close as possible. So I say, we're all mortal. So what I'm trying to do is basically kick the can down the road. All the bad things that tend to happen to women in their 60s and 70s, I want to kick it down the road so that they don't happen until they're in their 90s or hundreds, So, if they start having hypertension, if they start having cataracts, glaucoma, or any signs that are associated with osteoporosis, the aging, all the bad stuff, it's just delayed by 25 years. So you get 25, 30 extra years of optimal health where you don't have chronic diseases that you have to deal with in your life. That's really my goal for myself and for my patients, to really, just have this gigantic few decades even of healthy living without chronic disease. And most of the chronic diseases are really diseases of deficiencies that start with deficiencies of hormones, and there's this, like I said, complex, like thyroid. There's estrogen receptors on the thyroid gland. Without proper estradiol levels, your thyroid gland can't work properly. The whole gut microbiome transforms in a negative way when you don't have enough estradiol. I mean, every organ system is negatively impacted. You don't make nitric oxide to keep your arteries healthy, and you start having stiffer arteries and plaque formation, so everything is related to optimal presence of these vital life hormones. That's why I don't call the hormones from the ovaries sex hormones anymore. I call them life hormones, because they're really intrinsic to a healthy life in every organ system. And so, I'm just chugging away, doing the best I can, but I want women who are on these static doses, with estradiol and progesterone every day, to know that there are other options, that this is their choice. And if they like it and they're happy and they're doing this with total understanding, I support them, but if they say, but I didn't even know, no one ever told me that there may be a better way, and I'm okay to have bleeding every month, I'll make that sacrifice for having optimal everything, at least closer to optimal. then they should be given that choice. That's all I want. Give people education, give them choice.
Wow, I can never get past one question with you, maybe two. I'm so happy to have you on here, and we're gonna have to wrap it up, but I want to ask you one more question based on all this. You've given us so much information to digest. I hope everyone's taking notes. So the optimal levels, if a woman is going through perimenopause and she still has some hormone fluctuations, okay, they're all over the place. We can't predict it. It's hard. I understand why some doctors don't even want to test because it's just hard to be accurate and just start with the hormones. If we are cycling things in and out, and even if you're static for that matter, how do you know what is the optimal level for a woman? Because right now, was as I understand through everything you said, it's like, okay, when you've got the period, that's probably the sign that you're an optimal level. Are you doing blood work as well? And being
Mhm.
optimal, okay, let's say you have a period and just, sacrifice that. But there are women who all the women react so differently to the hormones. Some of them, when they're too high, they have breast tenderness, or they have weight gain, or they have other problems that they didn't expect. So how are you managing all of this with with the optimal dosages? And how do we know we are in the optimal zone, which is another question
Well,
other than the
the
periods?
later in the process, women, like we'll say, once their ovaries have now stopped making hormones, they're the easiest ones because I'm not having to fight with their own ovarian function anymore. So you're right, though, perimenopause is a challenging time because women are making their own hormones and it's unpredictable. If possible, I'd like to get a menstrual mapping, and there are a number of companies that do these cycle mapping where you can actually collect urine through multiple times during the menstrual cycle. And it's amazing how some women who are, say, 45 and they still have regular cycles, but they don't feel right. Their sleep is impacted, their mood, they may have palpitations, they may even have some night sweats, and they just don't feel themselves. They really feel different. And when you do the cycle mapping, you see that everything is like miniaturized. Their estradiol spike, instead of being like that, is like that. Their progesterone peak, instead of being like that, is like that.
Mm.
And those women, I give them supplemental hormones. So in the perimenopause, I call it hormone supplementation. And in the menopause, I call it hormone replacement, so it's supplement. Now, I always tell women that you're a moving target. We have to be resilient, and we have to be, sort of like adventurous, to do this. But so I call it a safety net. When I give hormones in the perimenopause, it's like a safety net. It keeps them from falling too low. Okay. It's not suppressive. It's not like birth control pills, which shuts their own ovarian function off. It's additive. So I say, I'm not controlling your own hormones to any great degree here. So if you have wacky hormones, I'm just giving you a baseline, a safety net, okay? So that you won't, the goal, and this, there's no like proof of this, but the goal is so that you don't have huge fluctuations, because part of the huge fluctuations is because the estradiol level will get too low. So the brain, which has sensors to the estrogen, says, oh, not enough estrogen. So it shoots out through the pituitary higher amounts of LH and FSH. So whoop, the ovaries, which still can respond, they're not lost to function yet. They still have some capability. They will shoot out suddenly like super high doses of estradiol because the FSH and LH went so high. And then the brain says, whoa, now there's too much. So then the FSH goes down. So then the level goes down. So it's like a roller coaster. So by giving sort of foundational safety net hormones, it hopefully will keep those huge surges. Now, you can still have some craziness, but hopefully you don't have the giant ups and the giant downs, the giant ups and downs, which is what triggers migraines and mood swings and breast tenderness and sleep problems, all that. Like, whoa, it's like, what's happening here? So to try to just sort of be on a more even keel. So that, and I do see that happening. Once again, no published data, because the conventional world doesn't even believe perimenopause is a condition that should be treated. But if it is treated, they say just put them all on birth control pills and just take away their ovarian function, stop their ovaries from functioning. I try to work with the ovaries I try. Sometimes you have to do what you have to do if someone's having hemorrhaging, you got to deal medically with the situation at hand. But in terms of trying to control just the crazy hormone swings, I try to give that safety net of hormones. And then, you can't really in that group be measuring all the time because it is fluctuating. So you really go more clinically, like what's happening? Are their cycles regular? How are they feeling? Because you're not going to be giving a dosage that's going to create some kind of wildly high level. You're just not giving any kind of dose like that. So you just kind of, perimenopause is a lot of clinical management. After in the menopause, when they're not making hormones at all from their ovaries, that's where measuring levels becomes more appropriate because you want to see where you're at because you're not working in conjunction with crazy ovaries. It's what they get is what you give. When you're doing the perimenopause, it's like you don't know for sure. So you're just trying to keep things from going too crazy and having your patient have a good life and not go into all kinds of symptoms. In terms of like weight, estradiol actually prevents weight gain. So it's like women, as a general rule, it's very sad, their bodies will naturally start collecting visceral fat as they proceed through perimenopause and into menopause. They say, what's happening to my waist? Why do I have this belly fat? What's going on here? Because estradiol controls all the appetite signals from the hypothalamus. It controls fat function. It controls the fat hormones, leptin, adiponectin that control appetite, that control fat burning. So without enough estradiol, you get dysregulation of your adipose tissue, and it starts to accumulate in the viscera and around the belly. But estradiol also is more about fluid retention. So think of, and progesterone is more like a diuretic. So it's like a water pill that, so if you have sort of these imbalances, especially in perimenopause, you can have a lot of fluid retention, and then you can have water weight, and feel bloated and that sort of thing. And in those women, they often will do better with higher amounts of progesterone. So once again, this is like a clinical picture that you're trying to manage people. And definitely for clinicians, doctors, nurse practitioners, this is not for the uninitiated or for like just assembly line treatment. This is highly personalized individual care when you're talking about this sort of thing. You can't like give cookie cutter treatments to these women, and they're like moving targets as well. So you really have to look at the whole picture, and it could be as simple as eat less salt. Some people are very salt sensitive, and just by not having all that salt and having better hydration, there's a lot of like other tricks that you can, even herbals that can sort of act as mild diuretics. So there's a lot of tricks to the trade here. So this is like where the real personalization of healthcare really comes in, and also reassurance that this is a phase of life that, it's going to change, and you can look at it in different ways, but it's definitely going to be changing. You're a moving target in perimenopause. And, I give everyone the full options, even the option, if short-term they wanted, of suppressing the ovaries. I mean, I'm here to align with people's wishes as opposed to being a dictator. I just, like, once again, I really am about personal choice and informed consent. And for people, like, even like if you go into a restaurant and the waiter says, oh, we have the best special today, I highly recommend it. And you say, I want to order something else, so I could say, I really recommend this, and then the patient says, well, that's nice, but I want something else. That's okay. It's like, I just give my opinion, my recommendation, but I give other options so that for each patient at each stage of life, she can make what she feels is the best decision for her.
Yeah, that's exactly what we want all our doctors to be, whether or not they like hormones or not hormones, just to give you the information and let you make the decision. And as well to be trained well enough to know what all the options are, because it seems as though there's not a whole lot of that either. Just to go back one question regarding the perimenopause phase, the safety net that you're talking about, it sounds like that's where a moment you're not going to do physiological optimal dosage. You're going to try to keep it a bit low. Is that how you're dealing with the perimenopause pause phase?
Yeah,
Or
generally, because they're still making hormones, right?
yeah,
So it's really a safety net because I'm trying to keep them from falling too low, or then going too high as a sort of like the flip side,
yeah,
like the response, the boomerang kind of a thing.
yeah.
So yes, it's perimenopause is not treated identically to menopause because it's really a different phase of this whole process of ovarian aging. And you have to be light on your toes because everyone is still, like I said, in that phase, a changing a changing individual. And some
Mhm.
people can suddenly stop making hormones, and suddenly they really move into that other phase. And you got to, be aware of that. So, it's a challenge, but it's a fun kind of a career when you see how much people can thrive when you work with them and that you educate them. And then like the other thing that's like, I call it nature's gift to women. It's foods that have phytoestrogens. So, incorporating all the lifestyle, like exercise and eating the right foods, a heavy plant-based focused diet, working on sleep, stress management, because women, all people have an autonomic nervous system. Women are more prone to the stress phase called the sympathetic instead of the calming natural baseline, which is the parasympathetic or what we call vagus nerve or vagal tone. And through doing various mind body techniques, we can actually keep women in a much less stressed state so that they feel better. Their hormones are optimized. They don't have like crazy high amounts of cortisol, which can cause weight gain and sleep problems. And they optimize sunlight and melatonin and serotonin. So it's not just hormones. I always say that's one of the things I dislike about a hormone clinic because hormones are foundational, but not sufficient. It's like building a house. You start with a foundation, but you can't move a family into a foundation. You got to put in the walls and the roof, and you got to put in all the electrical, the plumbing. So hormones are foundational, but they're not sufficient. If you just do hormones and throw hormones at women, especially, insufficient amounts, and then you don't do any of the lifestyle things that are essential to optimize healthy living and longevity and everything else, you're not going to really get the end result that you're desiring. So you have to do it all. And that's really an important takeaway that hormones are foundational, not sufficient. There are many young women nowadays. It's so sad. I see them all the time. They're young, they're in their 20s and 30s. They have totally awake, functioning ovaries, but maybe the ovaries aren't working well because they're so inflamed and there's a lot of other problems going on. So they have hormonal imbalances and fertility problems and period problems, but they have young ovaries from a chronological point of view, and they're metabolically unhealthy. They are early, like they call it metaflammaging, really like premature aging due to metabolic dysfunction where everything is deteriorating at the wrong time. So just being young doesn't make you automatically healthy, not anymore these days. And so at every stage of life, you have to optimize lifestyle. You have to. That is not an option for being healthy at any stage of life. And if anything, it becomes even more critical from perimenopause on. So, don't just do hormones and think you're done. Okay.
Yeah,
No, you got to do it all.
I agree 100%. I always say you can't out hormone a bad diet and lifestyle. So
I
it's,
love that.
yeah,
Yeah.
comes all together as a package. So I'm so glad you came and spoke to us, and you gave us so many golden nuggets here and really educated us in different ways of taking your hormones. And of course that we should have another podcast talking about all of the lifestyle changes and diet changes that you see with your patients, and in addition to treating them with hormones, because there are women who opt out, okay, for whatever reason or another, and they want to know, how can I optimize still my brain,
Oh,
my
yeah.
heart, my bones? And you've been in this game for a long time, and not just with the hormones, and you've been in the alternative medicine space and functional medicine space for ages. So I know you got a lot of great tips, but I'm gonna have to let you go. And I would love for people to know that I'm not sure, I think you still have the free ebook, the Menopause
Mhm.
SOS. And this is all what we
Sure
can do
do.
from, yeah, from a to optimize your health from a lifestyle point of view for your menopause transition. I'll have that link in the show notes, and a great book that I love too. I have that as well. And I refer to it very often. It's called Menopause 50 Things You Need to Know. And I'll have a link for that. And you got your website, integrativemgi.com. I've got your Facebook, your Twitter, Instagram, all your social media links in the show notes. Is there anything else that you'd like to share? Are there events or things that are coming up or programs you're putting together that we should know about?
Well, I am hoping to create more courses. So, if you sign up from my newsletter, then you'll be able to, you can go to my website, then you'll be able to be aware. Also, I'm on, like a lot of conferences, and we post a lot of different events that I'm on. So sign up for my newsletter, and then you'll know all the different things that I'm doing, because it's always a lot.
Yes, you are a true super ager, really so active, doing so many things, still helping women, and I commend you and so grateful you're here with us, and I hope to have you on for a fourth time if possible.
Absolutely.
Oh, have a great day.